in my perspective, PSMA PET is clearly a game changer, and it's really been an honor and pleasure to work with Tom Hope at UCSF and with Jeremy and Rob Ryder at UCLA, and we're a major accrual to the PYL trials as well. The rationale is clear on this. Conventional imaging with CT and bone scan has insufficient sensitivity. Rarely have I seen a CT or bone scan play a major role in management of patients. Generally, these are just not informative studies. Is it sensitive? I'm just showing you the results of the PYL study here, the Osprey study, and this was a study we were the highest accrual to. Cohort A were enrolled men with newly diagnosed high-risk cancer planned for radical prostatectomy and lymph node dissection. These results were Dave showed these nicely. I want to point out that, again, we were the major accrual to this. The median PSA was 9.7. So what really got people into this study was Gleason grade. So 81% had Gleason 8 through 10. Only 28% had T3 or 4 disease. So they were high risk, but they weren't really high risk. And I think that accounted for the sensitivity overall of 40%. If you look at lymph nodes greater than 5 millimeters in size, it was 60%. The other thing I want to point out here as a surgeon, the gold standard here was a lymph node dissection. As I mentioned yesterday, I'm not sure that lymph node dissections are the gold standard, because if you're trying to remove a normal sized lymph node, clearly when even you do an extended node dissection, you can never be really sure that you've gotten all the nodes. And I've been humbled by doing a node dissection in the presence of a positive PSMA, and then getting the PSMA afterwards to show that the node may still be there. This is especially treacherous when you're going after these presacral lymph nodes or perirectal lymph nodes. Work with Tom Hope, we looked at a meta-analysis for sensitivity and specificity. Overall was about 74% for sensitivity. Specificity, as mentioned by the other presenter, is actually quite high. So if it's positive, it is usually really positive. I also want to point out in David's presentation, we have an update on the PYL trial showing that the accuracy of localization is actually quite high. It's actually higher in people who have had previous ADT compared to people who have not had ADT, but about 85% or higher, you'll correctly localize the site of disease. Jeremy showed this. This was a study from Australia where they actually looked at the equivalent findings, management effect, and radiation exposure on people who underwent PSMA PET imaging, PSMA PET CT compared to conventional imaging. What all of us in the room will show here that you had fewer equivocal findings when you used PSMA PET compared to CT and bone scan. And we see all the time, radiologists will point out maybe 5 to 7 millimeter lymph nodes that are indeterminate for detection of disease. Management effect, again, is consistently, as I'll show you, around 30%. So if you look whether it's at the time of recurrence or pre-treatment at the time of diagnosis, you'll change management about 35% of the time. Radiation exposure is actually lower if you go with a PSMA PET-based strategy than conventional imaging. This again just shows the area under the curve, specificity and sensitivity for conventional imaging for whether it's any metastatic disease, pelvic nodal disease, or distant metastases. PSMA PET outperformed conventional imaging. There's a change treatment plan. I'll just show you the results. I think this is going to be discussed later on with regard to radiation therapy. It is, in our experience, it changes. We see major changes in radiation plan in about 30% of patients and minor changes in about 13 to 15%. Major changes occur because about 30 to 40% of the lymph nodes identified are outside the standard fields for both radiation and surgery. And in addition, with radiation therapy, normally, and correct me if I'm wrong, the radiation therapist, you'll get 45 gray across that field, but if you have a site of disease, you'll boost that with stereotactic body radiation. And that was a common reason for minor changes in technique. Felix Feng and others at UCSF have shown that, in fact, genomic scores are predictors of a positive PSMA scan. We're doing a lot of work right now trying to determine whether there's clinical pathologic features which predict for a positive PSMA, PSA, grade, genomic scores, to try and identify the people who most benefit from doing the PSMA PET scan. I want to point out that I think we're going beyond radiographic imaging to intraoperative imaging. And this is our work with Intuitive. Intuitive has a novel fluorophore. So IS-002 is a fluorophore linked to a PSMA targeting small molecule. And Rob Ryder's in the room is also quite interested in this intraoperative imaging. But we're conducting a phase 1 study at UCSF, and we're 2/3 through it now. In fact, we're almost done with it. And our patients are getting the fluorophore 24 hours ahead of time. They come into surgery, and of course, on the robot, we have an advanced Firefly camera. So we turn that camera on to allow for intraoperative imaging. And again, these lymph nodes are frequently normal-sized lymph nodes. So the hypothesis being tested is intraoperative imaging will allow us to excise cancer more completely and result in a more therapeutic intervention. This is a good example, in my opinion, of, you can see, advanced technology which could be disseminated quite quickly, because the advanced Firefly camera sits in these robots currently, and even the SP robot by early next year will have an advanced Firefly camera in it. This is preclinical work done by Hao Win at UCSF, showing in a xenograph model that you'll identify the lesion. It'll light up quite green here. He left a little behind, so-called positive surgical margin. This was the initial work, preclinical work done before we started the study. We're 2/3 through the study now, and what happens is, again, the patient gets the fluorophore 24 hours in advance, comes into the room. We'll go ahead, turn the camera on, do the dissection. We have a fluorescent scanner in the room, because we'll do on-site scanning, and then we have a closed field scanner which actually looks at the histopathology as well. And of course, we're in the process of looking at the histopathology. And again, the patients eligible for this trial are the CAPRA 6 or higher. Again, these are T3, high-grade, high PSA patients. There are this says trial at midpoint. We're actually at patient 22 of 26. Of those with complete histopathologic data, we identify the tumor fluorescence in all patients. The only adverse effect we have is a transitory green urine. They have no other side effects to this. It clearly outperforms standard imaging, white light imaging, and conventional imaging. I'm just showing you here a patient of mine, which the bladder neck lit up quite high. This was residual disease resected. Another patient where we saw residual disease as a prostate were out. We see the neurovascular bundle here, and this was not identified on white light. We see that we turn the fluorescent camera on. We see some residual disease along the surgical margin, and that was excised and found to be residual disease. Here's a lymph node lighting up green as well. So it's safe and well tolerated. We've actually arrived at a very good dose, because we've arrived at we went high in the dose, and then we went down lower to give us an optimal dose. Phase 2 trials are being planned. We have trial sites being selected currently. I am very upbeat about this. We need to determine whether or not it has a major impact on outcome. I think there's no question PSMA PET is a superior imaging agent compared to what we're doing with conventional imaging. I think we're doing too many worthless CT scans and bone scans. I think there's no question in my mind PSMA PET is a better test. I do think it clearly is changing treatment plans. I think that's without question, we're changing the way we're treating these patients. I think what we need to determine is whether or not the ultimate outcome is changed by the interventions that we're doing. There are 2 trials that are looking at this. One is the primary endpoint is success rate of patients with unfavorable intermediate risk and high risk prostate cancer after standard radiation versus PSMA PET-based radiation. I think this is going to be a positive trial. Another one, which the Moonshot program undertaken by the NCI, which we're part of, which looks at the impact of a negative PSMA PET on disease-free survival over time. Another endpoint, which is interesting to me, of course, is whether or not the PSMA PET allows us to direct additional therapy and determine the impact on progression-free survival. Our phase 2 trials on the intraoperative fluorophore are actually looking at the impact on progression-free survival. So in summary, both PYL and gallium-68 are proof of the evaluation of high-risk patients at diagnosis at the time of recurrence. Such tests are more sensitive and specific than standard imaging and will replace them. I think there's no question in my mind that we'll replace them, and I think that's going to happen within 6 months' time. I do think they result in a change in management in a significant number of patients. However, the impact on long-term outcomes, overall prostate cancer-specific metastases-free survival, remains to be determined.